I am Susan Elliott, and I'm a clinical nurse specialist at the Monroe Carroll Jr. Children's Hospital at Vanderbilt in Nashville, Tennessee. I follow all of the newborn screens for our NICU patients and also help with issues with newborn screening in our newborn nursery. Newborn screening has been in place for over 50 years, starting with the original test for PKU or phenylketonuria. Some of the old-time nurses may still refer to this test as the PKU test, but now we are actually testing for more than 40 different analytes that can predict up to 60 different metabolic and hemoglobinopathy problems in the newborn. It's very important that this be done in a timely fashion and be done properly so that the specimen can get to the health department quickly, and if there is anything that is wrong as far as an abnormal result or an unsatisfactory result, then the PCP can be notified immediately for follow-up. After an infant is born, our medical receptionist usually will fill out the basic information on the newborn screen form with the infant's name, gender, date and time of birth, the mother's demographic information, and the PCP information. And after 24 hours and before 48 hours, the newborn screen is going to be obtained by the nurse caring for the infant. The heel is warmed, the heel stick is done after identifying the patient, of course, and the blood spots must be specifically placed on the filter paper in the correct and proper order. Then the specimen is going to be dried for 3 hours before it is sent to our laboratory here at Vanderbilt for processing. Then our specimens go by courier to the State Health Department lab.
My name is Christine Mckeever. I'm the newborn screening division manager and manager over the tandem mass spectrometry section. We are the only newborn screening laboratory in Tennessee for public health. So all of our specimens come from varying areas of the state. There is a state mandate that all babies born in Tennessee must have a newborn screen. It's in our Department of Health rules and regulations, and so hospitals that are or birthing centers know that they should collect a specimen within 24 to 48 hours and send it to the state laboratory for testing. Mail call usually happens around 9:30. The specimens arrive at the laboratory usually through Federal Express, the Postal Service, by courier or by UPS, and all of the staff assemble and we check the envelopes to ensure that the mail is actually ours, because we don't want to open somebody else's mail. And then the specimens are taken out of the envelopes. They're given a date and time stamp, and that's in accordance with our licensure regulations to show when it was received into the laboratory. And then lastly, those that are considered to be unsatisfactory, those are reviewed by one of the management team just to ensure that the specimen is truly unsatisfactory, or if the specimen can be salvaged. Mainly there are 1 or 2 spots that are still of good quantity, or it's a test that you only require one test to be run, for example, a congenital hypothyroidism, or it's in here for cystic fibrosis. So there may be one quality spot that can be salvaged just to do that particular test. Once the specimens are accessioned and given a Tennessee Department of Health accession number, then the punching process begins. We have a punching order based on the incubation period of the test, so that we can maximize how quickly we have turnaround on our results. And the reason why we do this is because, like I said, they have a longer incubation time, so we start them earlier. That way we can maximize the amount of results that we're able to report at the end of the day. When our testing is completed and all of the demographic information has been entered into the system and checked, then we merge those results from the instrument into NATIS, and then our reporting process begins. We send to case management or the Family Health and Wellness group a concise list of all of the abnormal patients that we are reporting so that they can go into the LIMS system, find those patients, and contact the appropriate provider. And we kind of try to strike a fine balance to make sure we're not missing any babies, they're not falling through the cracks or reporting them as false negatives versus too many false positives.
My name is Pam Isom, and I'm the program manager for the newborn screening area. We have newborn screening, hearing, we have newborn metabolic screenings, and we have CCHD and lead follow-up. After the state lab faxes over the results, our follow-up nurses that are the case managers will process them through our Neometrics computer system. After that, they call the physicians and report the results out to the physician so they can get the patient back in for additional testing. Depending on the results, they may call the tertiary centers, which are the centers across the state that do the confirmatory testing. We will call them if the results are critical. They will consult with the pediatrician or the PCP office to determine the next test for the baby. The primary function of the pediatric follow-up case management nursing staff is to ensure that every baby born in the state of Tennessee gets a newborn screening filter card completed and gets all the genetic testing done off of that. The other primary function is to make sure every baby has a hearing screening before they leave the hospital. We follow up with those hospitals to make sure that there was a significant reason that the baby didn't have the blood spot done. The hearing reports, we have weekly hearing reports that come out that tell us what babies did not have the hearing screening done. With the metabolic testing, we try and do that as fast as we can. Many of the diseases are time sensitive. If the baby goes very long without a diagnosis, there's a risk of developmental delays and possibly death with those. Communication in case management takes a lot of effort. We try and touch base every day so that we know what each individual has planned, what we're behind on, if somebody's out sick so somebody else can pick up that workload and do it. It doesn't take a lot of time, but at least of a morning and in the afternoon, as the afternoon begins, we do touch base with each other. We may have a brief 5-minute meeting to kind of see where everybody's at and what we need to focus on for the rest of the day. Having worked in public health for almost 19 years, I can say this is one of the most rewarding positions I've worked in. I get to work with a dedicated group of nurses whose primary goal is to save the lives of infants. Each one of them has a personal satisfaction. It's very rewarding when we get the elevator results in, and with a matter of minutes we've notified a tertiary center and the primary care provider, and that baby's life has been saved many times.